Hello and welcome to Patient Care 222 or PTA 222 Patient Care Skills 1. Today we're going to be focusing on the shoulder and scapula. The objectives for the lecture today is to go over data collection and documentation and discuss manual therapy for the shoulder and scapula and exercises for the shoulder and scapula. When you get in the next class, there will be presentations for the cervical spine, and you will watch those presentations in preparation to write a SOAP note or a treatment note for that treatment. And I want to go into a little bit more detail with you today about what is expected in your data collection and documentation. Some of this will be review, but it's always good to get information reviewed and hearing different perspectives. And even when you get into the clinic, your clinical instructor may still have even more particular things that they want you to focus on with your documentation. We will also in that next class, we will review case studies that are found in the PDF for this presentation. And then we'll get to the fun stuff, which is lab. And in lab, we will be doing palpation and reviewing all these exercises and discussing how to progress and regress these exercises. So first, I want you to pause the video and think about what are the main components of a PT note? What do you know so far as physical therapy documentation? And why is it important to write a good note? What does it mean to have a good note? So go ahead and pause and think about that while I pull up our next presentation. So the acronym for the documentation that we normally do is SOAP. So we'll talk about what that means in a moment. Remember, documentation tells the story of the patient from start to finish. If someone doesn't know the patient, they should be able to pick up the chart and identify the step-by-step progression from the initial evaluation to the discharge. So the primary PT will evaluate the patient based on a complaint that they have. Maybe the doctor has sent them to physical therapy with a prescription for physical therapy interventions. The PT is going to do an evaluation that will include taking measurements of certain body parts, range of motion, manual muscle testing, special tests. They will create a plan of care. So in that plan of care, you will see information on the initial evaluation that tells you as a physical therapy assistant what you can do in those follow-up visits. So your follow-up visits will follow that plan of care. And then at the end, the physical therapist will write a discharge summary that will summarize the entire plan or the entire episode of care. So why are we doing this? We need to identify and record the most relevant information in our subjective section. That is the S in the SOAP note, what the patient is reporting. Then we need to determine the most appropriate objective findings for the pre- and post-treatment evaluation. So before you start today's treatment, the treatment at hand, you want to pick out something that's the most appropriate in the objective findings from the initial evaluation, and be prepared to evaluate or to measure that. And you can use that as information for your treatment as well, to document why you did your treatment, because range of motion was limited. And then you can determine if that was successful by remeasuring that objective findings. You want to document all your treatments provided appropriately, and I'll talk about that in detail in a moment. You want to formulate an assessment that is valuable and meaningful, and we'll talk about that as well. It needs to relate the content of the subjective evaluation that you brought in today, the subjective data, with the objective data that you've gathered. And then you're going to construct a plan that identifies areas for progression and regression as appropriate. So here's a sample patient Sarah Sample is a 36-year-old female status post motor vehicle accident who was evaluated a week ago. She had complaints of 7 out of 10 left upper trap pain. Her cervical range of motion was limited, with right side bending being 10 degrees. Manual muscle testing was normal, 5 out of 5 for bilateral upper extremities, except for the left shoulder, the flexion and abduction were 4 plus out of 5 and limited because of pain. The physical therapist gave the patient a home exercise program, including left upper trap stretching, posture training, and cervical isometrics. The patient is arriving today for the second visit. So I want you to think about, what would you ask the patient for your subjective data? What would you want to know? So let's go back, take a look at this, and pause the video so you can think about what you would ask. Write down 3 or 4 questions. What would you ask this patient? Remember, that's going to dictate what today's treatment is going to look like. So examples of questions that you can ask your patient is, if they're in the hospital or skilled nursing, you can ask them, have you seen your doctor lately? Have there been any new orders? Some stuff that we should know about. How do you feel? How did you feel after your last treatment? So that tells you whether or not the previous treatment was successful, or if it wasn't successful, maybe there was a part of the treatment that wasn't as helpful, and you'll find that out by asking how they're feeling after that previous treatment. And then you can direct them to more specific areas of information that you need. You can ask if they're doing their home exercise program. Are you compliant with this home exercise program? And find out if they're compliant. And then, can you demonstrate? You might ask them to demonstrate the exercises during your treatment. Has there been any specific improvement in function? And you want to find out specifically what function has improved. Is it reaching behind the back, or is it reaching overhead? Is it both? Is it neither? And then you can also ask if there's been any changes in your medication. So if the patient is complaining of a 7 out of 10 pain today, and they're not taking their pain medicine, or maybe they are at a 4 out of 10 pain, whereas last time they were at 7 out of 10 pain with pain medicine, and today they're 4 out of 10 pain without pain medicine, you can gather that information, and you can summarize or surmise that the pain is actually improved because they're not even taking pain medicine now, and their pain level is lower. So don't simply ask, how are you doing? If you ask how you are doing, make sure that is a leading, that can be your opener to kind of break the ice with the patient, but you really want to try to be specific in directing the questions towards the data that you need. So if you really specifically need to know if they've been able to sleep through the night, ask that question. They may have a goal of sleeping through the night, being able to get comfortable in bed in order to facilitate sleeping all night uninterrupted. So now let's go back to Sarah's sample. And the next thing I want you to think about when you're looking at there's only a little bit of objective data here. There's not a lot for you to go off. But what I want you to think about is, what would you measure? So pause the video, look this over, and if you were to pick one thing to remeasure, what would it be? Remember, your objective section needs to include data collected, like tests, measures, range of motion. Range of motion could be like functional range of motion, like can they do a full squat to assess functional range of motion, or did you get a goniometer out and actually measure the range of motion in degrees? What is the manual muscle testing? Pain is listed here. Oftentimes pain is listed in the subjective section, unless you have some kind of a physical visual analog scale that you're actually having them fill out or point. That data could go into the objective section. But oftentimes, like I said, it's usually in the subjective. Vital signs are also important. Some of your patients you will be required to take vital signs for. And others, you may, knowing what their medical history is, may point you in the direction of, maybe I should have a baseline blood pressure So that way, when we go to do exercise, if they have a complaint like lightheadedness or a complaint of headache and nervousness, maybe you might check their blood pressure again and see if it's changed, see if it's gone up or gone down with the activities that you've done, and make sure it's still in a safe range for that patient. You can also include specific tests like the time up and go test, single leg stance, other very specific that are not necessarily, or specific functional tests are not necessarily strength and range of motion. Description of the patient's function. So describe the patient's ability to move in bed or transfer or to ambulate. We want to know, like, what does this look like? One person's gait is not necessarily going to look like another person's gait. And if your focus on therapy is to improve gait, we got to know what it looks like. And you can't really post a video of their gait in the notes. So you have to describe the gait. You have to describe the discrepancies. Observations about the patient, including if there's a wound, describing it, if there's a new wound, if there's a new bruise somewhere, what the scar looks like, the surgical scar. Is it weeping? Is it open? Is it closed? Is it healing up? Does it look like it's healing well? Is there redness around it that would indicate that it's not healing well? Is there a temperature change on the skin that would indicate warmth and maybe an infection? So all those observations go in the objective section. Any movement strategies, if they have to use their hands to push themselves up from a stoop position or bending forward flexion for the lumbar spine, that's another good observation to record. And then, of course, you include your treatments. So you document your treatments in the objective section. You want to include your accurate dosage and your patient response. Don't remeasure everything in the initial evaluation. So as for our sample patient, I don't know that I would measure strength at the second visit. Since manual muscle testing was limited by pain at the first visit, and especially if the pain is not much different today, I'm not going to torture the patient by having them do manually resisted hold and don't let me push you kind of tests. I would defer that to, a time where it seems like it makes sense, where there's time for pain to be recovered and time for muscle strength to actually increase. It doesn't increase overnight. You want to consider the goals of the previous interventions, the anticipated interventions. So our anticipated interventions with this patient who has cervical spine issue might be, joint mobilization to the cervical spine or manual therapy to the cervical musculature. So perhaps we should look at the cervical range of motion prior to treatment, do the treatment, and then recheck that same range of motion at the end. When documenting treatment, make sure you document the amount or dosage, the equipment used, if any, the setting, the treatment areas, the patient positioning, the frequency, the duration, the length of rest breaks, especially if there's taking rest breaks because they have really poor activity tolerance. It's a good thing to keep track of, because then later, as if they're improving and their activity tolerance is improving, it should be well documented and very clear in the documentation that they used to require longer and more frequent rest breaks, and now they require few, if any, rest breaks. That's a documentation that insinuates that their activity tolerance is improving. Patient-related instruction. So if they needed education on the total hip precautions, then you would document that as well in the treatment section. That would be documented as patient education, or and so there's a code for that. When we get to documentation, you'll find out what that means. But right now, just know that documenting instruction, precautions, posture training sometimes falls into that. It can be considered a therapeutic activity. If you're having the patient perform the activity as you instruct it. So there's different ways of looking at those things. You just want to make sure you document it. Remember, if it didn't get documented, it didn't happen. So if your patient with a total hip arthroscopy, if they're a replacement, if they dislocate their hip and there's nothing in the treatment notes that indicate that anyone bothered to go over the total hip precautions with them, then that is a liability issue, right? So we got to make sure that we're educating our patient. Although I wouldn't say you document that in every note as a distinct treatment, unless there's a reason why you have to repeat that as a separate education. So just remember, you're going to be charging for each part of your treatment, and so it's just something I want you to keep in mind. And then you can also document any communication or coordination with other professionals. So with nursing, the doctor, with OT, your communications with the primary PT can also be documented under treatment. This acronym is covered in the video link that's in the primary PDF for this presentation. And so I'm just going to go over briefly what this stands for. And it's another way of looking at how to document treatment specifically. So the first W is, what was the treatment? Where did this treatment happen? Why was this done? So remember, if you're working on cervical range of motion, or you're working on unilateral PAs of the cervical spine, it's to increase range of motion. So putting the reason why it was done, it really helps for insurance payers to understand why you're doing something, and it ensures, almost guarantees, that you get paid for the service that you have provided. The parameters for the treatment, the positioning of the patient is extremely important. So we have to know what position the patient is in. Any assistance provided? Did they need contact guard assistance, max assist? Were they just standby assist, or were you just close observation? How much assistance did they need? Two other things that I want you to be aware of when you're looking at documentation are impairments and functional limitations. So an impairment is something like a decreased range of motion or weakness in the lower extremity. And then the functional limitation is what is going to result from that. Functionally, what happens when you have weakness in the lower extremity? And you'll have things like the knee can buckle with heel strike. There may be a decreased gait speed during training or gait training. There may be safety precautions or safety difficulties during transfers and gait training. So if the knee is buckling or the leg is weak, there may be safety issues. And they may be unable to ambulate on uneven terrain without assistance. So maybe they need a walker or a single point cane because of that functional limitation resulting from the weakness. Okay, so let's go back to Sarah's sample. Now she's come back to her second visit, and she's reporting an improved ability to turn her head and look up and down. Her pain is down to 3 out of 10 at its worst. She is compliant with her home exercise program, but occasionally has a catch when turning her head to the left. The objective findings are cervical active range of motion, right side bend, 15 degrees. Palpation of the left upper trap and cervical erector spinae are hypertonic and tender to palpation. Joint mobilization or joint grade mobilization grade is stiff with pain when providing a unilateral PA on C4 and 5. So the treatment is documented as grade 3 unilateral PA to left C3-4 facet joints, C4-5, and C5-6. And then after, so those 2 forward slashes means after that treatment, the right side bending was 20 degrees. So what I don't like about that is we are missing something. What are we missing in that treatment? Of the cervical spine? Think about what's missing there. Now, they also wrote down that they reviewed the home exercise program, but then they said see flow sheet. So now we're really relying on there being a very detailed flow sheet nearby. And I want you to think about what should be included on that flow sheet for the review of the home exercise program. Finally, they did therapeutic exercise, which I'm assuming they're going to also include on that flow sheet, but they documented it here as standing open book trunk rotation, 3 sets of 10, both sides, yielding right side bend going up to 25 degrees with 1 out of 10 pain. So again, I want you to think about how that was documented, and is there a better way that the treatment could have been documented? So go back to the WWWPA and look and see how you might do that differently. But I also want you to pause the video and think about what your assessment would be. So go back to this screen, pause the video. What would your assessment be? Thinking about how they presented at the first visit and how they're presenting today. The assessment is the most difficult part of the note, but it is very important. This is how data demonstrates the patient's response to the intervention. So that's what we're going to be summarizing here. If there is a change in pain level, a change in the impairments, or changes in the functional status, progress towards goals. So you definitely need to include something about the goals. Did they make any progress towards the first goal, which was to turn their head in order to pull back out of the driveway? And maybe that's a functional goal. Maybe they had a range of motion goal, but you need to speak to whether or not they made progress towards those specific goals. Was the goal achieved? Was there progress toward that goal or no progress towards that goal? Please, even if there's no progress towards that goal, make sure you make a comment to that, because then you're going to come up with an idea for how you're going to improve that the next time they come in. And if there was a decline in the patient status, you definitely need to document that as well. Do not simply say patient tolerated treatment well and leave it at that, or patient progressing and leave it at that. That's way too vague, and it does not tell an insurance company why you're going to continue with skilled therapy. So ultimately, you're telling the insurance company or the doctor or a case manager, maybe it's a work comp case manager, you're explaining to them why you're going to continue with skilled therapy. Why is it necessary? You want to indicate the relationships between impairments and activity limitations and any participation restriction. Unable to work, patient is now capable of doing 25% of their original workload, something along those lines that kind of indicates there's a relationship between these things. Relate what happened between the subjective and objective. So if they reported improvement, then you need to make sure you include that information. That information is important in your assessment. And the same thing with the objective changes. Make sure you report into your assessment that there has been an improvement in the cervical range of motion, and that's helping them get to the point where they can meet their goals for driving. So patient continues to have decreased cervical range of motion, which is limiting her ability to drive and reach into her overhead cabinets. Or patient demonstrated improved cervical range of motion and decreased pain since starting PT. Improvement in range of motion has allowed better ability to drive and reach in overhead cabinets. Now, what this does not say is skilled physical therapy continues to be necessary to achieve the aforementioned goals, or skilled therapy is still necessary due to moderate pain complaints and range of motion limitations. So make sure you are explaining why there is going to be another visit. If there are significant changes in the status of the patient, then you need to report it to the primary PT and make sure you document it. So here's a list of reasons that you should be reporting back to your primary PT, and make sure you document. Okay, so going back to Sarah's sample, this is the same as the previous sample, but now I want you to think about what is your plan going to be. So considering what you included in her assessment for the treatment, what is the plan going to be? What are you going to do at the next visit? Pause the video and think about that, or write it down. So the plan includes the plan for the next intervention. If there's a plan for consultation with another discipline, make sure you include the frequency and duration of the subsequent visits. So if the patient got a prescription for 12 visits and the PT's plan of care is for 3 times a week for 4 weeks to meet the 12 visits, and you're on visit number 3, your plan, your frequency and duration is not going to be 12. It's not going to be 3 times 4. What would it be? So think about that. Plan for the reevaluation or discontinuation of therapy. So if they're doing well and you feel like the primary PT should see them and consider writing a discharge, or writing a new evaluation or a reevaluation that has updated goals. So maybe all the short-term goals are being met. Maybe they're not being met and they need to be modified to a lower level of a goal to make therapy, to kind of refocus what the therapy is going to be concentrating on. And any plans to discuss with PT the changes in the patient's condition or specific patient goals, or any complaints that the patient has to the PTA. You can put that in the plan. The plan tells us where do we go from here and what instructions are still needed, what interventions and procedures need to be done. It's going to serve as a guide to the next PT or PTA to what to do in the next visits. And it may tell you to recheck something. You might say, well, we're going to have to recheck elbow flexion at the next visit. Or maybe now is the time you want to say, at the next visit, let's recheck the manual muscle testing for shoulder flexion and abduction. Okay, so for this plan, the patient will continue physical therapy with the PTA 2 times a week for the next 2 weeks. The follow-up with a primary PT in 3 weeks. The next visit, reassess cervical side bending and rotation active range of motion. Progress cervical stabilization training to include reaching activities. Be sure to cue the patient to maintain neutral spine with all functional activities. Initiate lifting up to 5 pounds, provided pain remains less than 2 out of 10 at rest. Continue with soft tissue mobilization and ultrasound if resting pain is more than 4 out of 10. So I want you to look back through that. And is there anything you would modify, or is there information do you think we're missing in any of the plan? Now, this plan does not say continue cervical stretching, upper trap, 3 times 30-second holds, chin tucks 3 times 10, scap retraction 3 times 10, elbow flexion with resistance band 3 times 10. It's not going through every single exercise. So, and especially not every single exercise with specific dosage, not necessarily. You could say progress cervical stabilization isometrics to 30-second holds from 10-second holds. You could say something like that, so that then the next therapist would look and say, okay, they were doing chin tuck or cervical isometrics. They were doing them for 10-second holds. It says in the plan that we can progress them to 30-second holds. Now I know what to do with that with that exercise. I might say continue with current exercise program with the addition of, and then add that extra exercise. I think the other thing I'm not super satisfied though is it says initiate lifting up to 5 pounds. I don't know what that means. Does that mean lifting like floor to waist? Does that mean lifting waist to shoulder? Is it lifting with the left hand, with the right hand, with both hands? So might want to clarify what type of lifting we want to do. But I do like that it says provided pain is less than 2. So I know like lifting a 5-pound weight is going to be a desired progression if the pain meets our criteria. And if the pain isn't meeting our criteria, it's more than a 4 out of 10. Maybe we're not getting to that. We have an alternative plan to continue with soft tissue mobilization and ultrasound if the resting pain is more than 4 out of 10. We might specifically say what muscles we're going to do soft tissue mobilization. We might clarify exactly what soft tissue mobilization technique we will use. So, just, think about how you can make this a little more specific without going into so many details that you're writing 7 pages. Lastly, sign your name and date. And remember, your designation is SPTA, so that's your professional designation. So I should see your name, first name, last name, student PTA, SPTA, and the date at the end of your note. Remember, consistency between the initial and subsequent documentation makes it easier for the clinician to identify progress or lack of progress. So if we're consistent in how we document, it's a lot easier to find the data we need. The PT will be more easily able to update goals and interventions. The PTA recognizes and reports its changes in status and communicates this information to the supervising PT so that they can adjust the plan of care based on those patient changes. Communication is key. We've talked about this before. I'm sure you talked about it in your professional behaviors class. But anytime you need to clarify interventions in the plan of care, if the patient's condition changes from when the plan of care was written, if the patient is not safe or comfortable during the selected interventions and your modifications within the plan of care have not helped, if no progress and the modifications within the plan of care have not helped, so if they're not making progress, then you need to talk to the primary PT. And when a goal or more than one goal has been met, you might need more ideas for what to do. They might need to have their goals reestablished, new goals established. Here's a copy of the SOAP Note grading rubric that I'm going to be using. So make sure you look at this when you're writing your note and make sure all the components are in here. When we're talking about the assessment, when I say valuable and meaningful, the assessment needs to include some information about their progress towards specific goals. It needs to also explain why continued therapy is necessary. That's what makes it valuable and meaningful. And is everything that's contained in the assessment, is it related to the content that you gathered in the subjective and objective sections? So is it related to that? It should be. Like you're writing the assessment for today's note, not the assessment for last week's note, right? Is the plan meaningful? So remember, the plan has to include the frequency and duration of the remaining visits and specifics of what you're going to do. So not listing every little thing with reps and sets unless you're increasing something for a specific reason. So you might say increased reps as tolerated, but say I would be more specific, increase to up to 10 reps or up to 30 reps as tolerated, or if tolerated, or if pain is less than 2 out of 10, something a little bit more specific so that if a different therapist never saw this patient, they could look at the plan and have a really good idea of what's going to happen. So if I look at your plan and I have no clue what's going to happen, then I can't give you all of those points. The SOAP note should be easy to read and follow. Make sure you double check your abbreviations, that they're actual physical therapy abbreviations. And then make sure you sign and date your note. Make sure your patient's name is on there. include the date. So you'll see date on here 2 times, right? Because we want to know, well, it doesn't say down here, but typically you're going to say the date that you signed. So date you signed your note is important. And if you're using a paw print, make sure you can still figure out how to enter a date in there. Okay, back to this. So this is the other video that I was telling you about on this PT Ed Solutions. So please take a moment to watch that video. When we're talking about the shoulder and scapula, something I want you to consider is the common site for rotator cuff impingement. This common site of pain is going to be at the deltoid insertion. So that's not necessarily where the injury is, but oftentimes the muscle itself will get hypertonic. So just be aware of that when you're dealing with patients with rotator cuff issues. There may be multiple areas of muscle hypertonicity and tenderness that you can treat, and that'll help bring some of the pain intensity down. But the root cause for a lot of rotator cuff issues is muscle imbalance. So there's one muscle working too hard. There are other muscles that are weak. There may be, because the joint tends to be relatively unstable compared to other joints of our body, those muscles have to fire and perform on cue and exactly together, or else that imbalance can create an environment for impingement. Rotator cuff muscle tender points also can refer pain down the arm. So when if you've got pain going down the biceps or the triceps or down into the forearm, and those muscles don't feel like they should be having an issue, meaning that they feel relatively supple and the patient's not complaining of pain, that may indicate that the pain is not coming from there. It may be a referral pain from a tender point in one of the other more proximal muscles. The subscapularis muscle, when it's tight, it will restrict shoulder external rotation. So I want you to consider about how it would be possible to do soft tissue mobilization on that subscapularis. There is some information here on the subscapularis in these videos here. Remember, these videos are from the massage therapist who I like that she paints the muscles and gives really good information on origin and insertion. And you can also refer over here to body regions in PhysioU. Go to surface anatomy palpation. Click on the shoulder. We've got bony landmarks anterior and posterior with videos on how to find those landmarks, including a list on the side of these areas that you can palpate. So you can click on those to jump to that portion of the video. And then also we've got soft tissue, and where you can jump to, to find pectoralis minor. That's going to go to the portion of the video that talks about how to get to pec minor. He's not pointing to pec minor yet, but he will talk about it in a moment. And have that pulled up when you get into lecture or into the lab at the next class, so we can talk about those and we can practice palpating, which is super important to do. We're also going to review these exercises. So I want you to take a look at these exercises and just kind of look through each one and be prepared to practice these in lab. When you're looking at these exercises, I want you to think about what looks like a beginner exercise and why it looks like beginner exercise. So if we think about active assisted range of motion, think about why a patient would be doing active assisted range of motion. Why would we not want them to try to lift up their arm with its own volition, with its own muscles acting? Is it because there's been a surgery and we really don't want those muscles pulling on the tendon? Or is it because there's so much pain when they try to move it that they might get better motion or mobility by not activating those muscles. So we can maintain some range of motion without activating the muscles. We can utilize a gym ball to help support the weight of the arm to do those active assisted exercises. Or against a wall, we can activate certain muscles in still a supported position, but maybe making them work a little bit harder to stabilize the ball on the wall. Rotator cuff exercises are going to look like external rotation and internal rotation. So gradually progressing from active assistive range of motion to active range of motion to selectively isolating certain muscles, utilizing isometric versus isotonic, and then going out of neutral, right? So here we are in neutral, and now we're out of neutral. And I want you to think about when you change the joint position, you're also changing the line of pull on the muscle. That could actually change the muscle's action. So you've got to look at where the origin and insertion are now when you're out in that abducted position, and how does that affect those muscles? We talked about scapular strengthening last time for cervical and thoracic. Things to keep in mind: don't forget about the cervical spine when you're doing these, even if you are doing these for the shoulder. So if you're doing the serratus push for the subscapularis, make sure they're still maintaining neutral spine so that you're not creating neck issues. Same thing on the gym ball. You'll notice that this guy is looking at the floor the whole time, maintaining that neutral cervical spine. When you get into these more advanced exercises, again, I just gave you that answer. This is more advanced because you've got resistance, you've got stabilization, you've got dynamic stability happening. You got to make sure, though, that if you're doing an exercise like this, that they're not dropping into too much lumbar lordosis. Same thing in this. The core muscles, the abdominal muscles really need to be kicked in and engaging and protecting the lumbar spine, while the latissimus is eccentrically loading into that flex position. We will go over the case studies in class. Have a nice day. We'll see you in class.